Last
Thank
week,
you.
last week we had a very fine class, and we are going to continue what we did last week. Last week, I gave you guys some advanced slides to go through so that we ran peptic ulcer today as short as possible, then probably continue with what we have to do today. So, I don't know if anybody has an issue before we start today's class. Anybody with any issue first? I guess there are no issues. I hope my course rep is available. Well, he's my honorable member in which I work with all the time. So today's work isn't going to be any extremely different. It's just an upgrade of what we had done last week. And so today's work is just typically going to be on PUD, peptic ulcer, peptic ulcer. So I guess we are ready to start the lesson. Can we all mute our microphones and then we start with our lesson? Please kindly mute your microphone so that we start our lessons for today. Mute all. Good. Okay, so today's lesson that we have ahead of us is just on, we're starting with peptic ulcer disease, PUD. Last week we were discussing gastritis. I think we did almost everything on PUD, just that there are things that we need to add up to make the PUD a full, topic on its own. So as you all know, peptic ulcer disease. From your previous educational background, you've all heard of it before. Just at this time, be adding certain little things to it to make it more complete and easier to understand. So to start with, we are saying that peptic ulcer is an ulcer of excavation found in the esophagus, stomach, or the duodenum. What do we mean by that? Mostly when we say peptic ulcer, people just kill their minds onto the stomach. Gastritis will occur only in the stomach. GERD will occur in the esophagus. But for peptic ulcer, it goes beyond the stomach. It can affect either the stomach, the duodenum, or the esophagus, or esophagus. So peptic ulcer could be gastric, with duodenal or esophageal, depending on the location. So like I said, you all know, ulcer means a sore. So it means when the sore occurs inside the duodenum, it becomes a duodenal ulcer. When it occurs inside the esophagus, it becomes an esophageal ulcer. And that when it happens inside the gastric gland, we can call it a gastric ulcer. And that we are saying that peptic ulcers are more likely to be in the duodenum than in the stomach. Why? As we go into as we go into the pathophysiology, you realize that we stand upright in most of the time. So by the virtue of that, gravity pulls a lot of the secretions of the stomach towards the pylorus. That is the lower portion of the stomach. And that as the sphincter, the pyloric sphincter keeps opening, some of these exudates will be released secretions into the duodenum. And that is why most peptic ulcers are duodenal ulcer. And that ulcer could be acute or chronic. That is, it can occur within a few weeks, we are done and it's gone. Or it can stay with some people for over 3 months and it becomes a chronic condition on them. What are the precipitating factors? Peptic ulcer is found in 70%, like almost 70% of all cases of peptic ulcer may have Helicobacter pylori causing it. And that is why in our hospitals, when cases ensue, we request H. pylori because Helicobacter pylori is known to trigger such inflammations and further excavation of the mucosa. And for gastric ulcer, for gastric ulcer, 90%. So we said that found in 70% of patients with gastric ulcer. That's H. pylori, and duodenal ulcer, 90%. And among the precipitating factors too is alcoholism or alcohol, smoking, like we said the last time, prolonged use of NSAIDs, non-steroidal anti-inflammatory drug, such as diclofenac, ibuprofen. I think we've explained it already. But what we refuse to admit in most of our local parlance is severe physiological stress. In fact, when you overstress yourself, you become relatively predisposed to peptic ulcer. And so most of the time when they come to the hospital, there are people who may have it. They run all tests or level, everything is negative. But if you don't ask their history to know as to whether they have endured some protracted or severe stress over the past days, you may not be able to give a proper diagnosis of the condition. Also, certain foods are known to precipitate, such as spicy and caffeinated beverage, like foods with caffeine. We talked about it last week. So what is just a pathophysiology? There are so many different pathways, but we are saying that the gastric and duodenal mucosa barrier consists of complex system made up of submucosa, epithelial tissues, and the mucous elements, which helps to protect the lining. An imbalance between the aggressive factors and this protective barrier lead to breakdown of the barrier. That is a mucous membrane. So it's like, you all know that acidity in the stomach is even as low as 3.5. That is pH. And that we all know that an acid of 3.5 pouring your skin is going to cause severe burns. But it's in your stomach and it's not causing burns because the lining of the stomach is also covered with mucus. So if any of the aggression factors or the predisposing factors is triggered, which leads to breakdown of that barrier, that is the mucous barrier, typically it's going to get the acid into close contact with the mucosa. And that's when these acids come into close contact with the mucosa, it excavates or it causes an ulceration. Sometimes start with gastritis and it ends with the ulcer. And then when the ulcer occurs, that is when we say that we have peptic ulcer, peptic ulcer. So you're saying that breakdown of the mucosa barrier results in diffusion of acid into the mucosa, which subsequently leads to the ulcer. What are the signs and symptoms that comes with peptic ulcer? Yeah, most people are asymptomatic. Most people with it, H. pylori will be asymptomatic until it becomes severe. When it becomes severe, the most classical sign, I think last week, I thought Abukari or whoever was asking of the classical sign. The classical symptom is what we call epigastric pain. Epigastric pain. Why epigastric pain? Because I explained the epigastrum. That is where the stomach is located, right? And so when you have pain there, we say that you have epigastric pain. It also comes with nausea and vomiting. And that when the ulcers are excavated, definitely it's a sore. When you sustain a cut, what happens? Blood comes out. But so in that same regard, for peptic ulcer, blood is oozed into the intestine. And that when you pass out stools, you see molecules of blood in there. Please mute your microphone. Please mute your microphone. Somebody saying Ewaha, please help us by muting it. And so passage of melena stools, feeling of bloated or full in your stomach. Why? Because sometimes they generate a lot of abdominal gas. They generate a lot of abdominal gas. And when that occurs, it leads to bloatedness. So yes, and there are major differences between the clinical manifestation of gastric and duodenal. I want students to read on them, but to read on it, no. Now for gastric ulcer, the classical sign is that merely you eat, it brings pain. In fact, I said you should read them, but I'm telling you. You know this already from your previous knowledge. For gastric ulcer, when you eat, there is pain. When you are hungry, you are fine. But for duodenal ulcer, when you are hungry, there is pain. When you eat, then you get relieved. So we are saying that gastric ulcer will come with eating pain, but duodenal ulcer will come with what? Hunger pain. So you should know that. How do we diagnose peptic ulcer disease? First, we do a comprehensive history taking. What do we mean? We want to know whether they've been consuming spicy foods, or today is Saturday, they might have attended the funeral since yesterday and they became the new distiller of the area, right? And they'll have to do physical examination. By physical examining, what do? We palpate. In palpation, we try to palpate the epigastric area in search of tenderness. In fact, when there's an ulcer inside the stomach and you palpate, definitely the patient is going to show signs of tenderness or rebound tenderness. We also do endoscopy, or what we call upper GI series, whereby we put an endoscope inside the mouth into the esophagus, and then we take pictures of the gastric gland to see whether there's an ulcer there or not. We also do barium x-rays. I know you've been taught, whereby we give patient barium, what they call the swallows, after which we take x-ray to see the location of the ulcers. We also have tests for H. pylori. For H. pylori, there are different tests. We can test from your feces, from your blood, even now from your breath, whereby they give you just something like a whistle. You blow air into it. When the H. pylori is within your blood, it is going to show positivity. How do we manage this? This is where the problem comes in, that I want all of us to take attention, especially during our practice. Now, medically, we call something triple therapy or quadruple therapy. I repeat, medically for peptic ulcer disease, it should be constant, a minimum of triple therapy, or what we call quadruple therapy. When we talk about the triple therapy, what do we mean? We are talking about at least 2 antibiotics and 1 proton pump inhibitor. We all know what PPIs or proton pump inhibitors are. They are the omeprazole, esomeprazole, lansoprazole, and then all the others. And then 2 antibiotics. So triple therapy means 3 drugs minimum, whereby we have maybe 1 omeprazole and 2, antibiotics. And that the 2 antibiotics, we are saying that they include either amoxicillin plus clarithromycin or amoxicillin and metronidazole, that is flagyl. So in most instances, when we do amoxicillin plus flagyl, what is cheaper, and it doesn't work, then we switch to amoxicillin to what? Clarithromycin. For quadruple therapy, it consists of bismuth, 2 antibiotics plus 1 PPI. And sometimes the bismuth can be even replaced with the same thing, whereby we give them antacids. So when it is so severe that we think the acidity is causing trouble, we are allowed to maybe add some NuGel or mixed magnesium trisilicate or aluminum trisilicate. I think the last time I explained to all of you the indication for use of magnesium trisilicate and aluminum trisilicate. So that is triple therapy. 1 antibiotic, 2 antibiotics plus 1 PPI. But for quadruple therapy, it is the triple therapy plus bismuth or any antacid to make it 4 drugs. And I share that the 2 antibiotics include amoxicillin plus flagyl, first line. If it doesn't work, amoxicillin plus clarithromycin. And so apart from that, there are other, combinations. They include triple therapy plus antacid plus antispasmodic. That is Buscopan, Sometimes when there are a lot of abdominal cramps, we add it to it so that it becomes quadruple therapy plus Buscopan. When they come in so severe, especially the students. Also for triple, we also have another combination that is triple therapy plus antacid plus narcotics. Like I said last week, we want to give them painkillers, that is narcotics. All we give is we give them tramadol. When the pain is from moderate to severe, they will go for, let's say, Pretidine. But most of the time, we want to give them paracetamol first. If it doesn't work, then we go for tramadol. What are the nursing care, prominence? First, we do the psychotherapy. Why psychotherapy? Among the predisposing factors, we say that stress is quite known. to predispose people to that. So you want to make sure that they are relieved of stress. In fact, there are patients who come to you with peptic ulcer that just by talking well to them, getting them relaxed, and reassuring them, the pain goes away. And that we also give them medication, like we did in gastritis. Let them avoid alcohol, let them avoid a lot of spicy foods. And then even if they are abusing NSAIDs, like I said the last time, a lot of our market women are having issues with this because anytime they close from work and they are tired, there are people walking through our Ghana markets with painkillers, very painful and very unfortunate. They call some of them power, but I think they have terms for them. And people buy them every evening after work. So as they consume for longer, they develop this condition. So you have to educate people so that they avoid a lot of this. When they are with you as a nurse, what do you do to check and record vital signs? And then you monitor intake and output. We also monitor patients' pain level using the pain scale from what? 0 to what? 10. I know you know pain scale already. Whereby for pain scale, 10 is severe pain, 0 means no pain. Then 5 means a pain in between, right? So 1 to 3 is mild pain, 3 to 6, moderate pain, 7 to 10, severe pain. Yeah, and that you also monitor intake and output. We also serve or administer all medications and then monitor its therapeutic as well as side effects. In diet, we tell them to take less irritating or spicy foods. And that because I said the last time, if you pump them with meals, they are going to vomit. You serve them meals in bits, but at regular intervals. And that they also avoid fizzy and caffeinated drinks. In fact, when it becomes so severe that people have severe GI bleeding, in fact, it happens a lot, whereby people can bleed from their stomach or their duodenum or esophagus, and then they become anemic. For them, we have to undertake chemotherapy or give them blood transfusion. I know you know blood transfusion so much that, and I know the advanced nursing team to be working on that. When people have this, the complications almost go the same as gastritis. It can be severe anemia. That is when they bleed into their own intestines. It can lead to intestinal perforations. When the intestine is perforated and any exudate enters the peritoneum, it brings about peritonitis. And that severe stomach ulcer, when it becomes so chronic for a longer time, may lead to stomach cancer, which is very common now. So with this, close this chapter. Let's listen to your questions first, and then I'll continue with my work for the day. Please, anybody with a question on peptic ulcer, let me see you by hands, and then we take it out from there. Felix, come on board.
Yeah, hello, sir.
Hello, Felix.
Yeah, sir. With regards to the treatment of peptic ulcer,
Yes.
the quadruple therapy and the triple therapy, is the amoxicillin a constant?
Pardon?
The amoxicillin.
Yes, it's a constant, yes.
So in that means you cannot take the clarithromycin and then flagyl.
No. I think you know, what do you call it? You know a mechanism of actions from pharmacology, right? And that for H. pylori, they sometimes they behave as they are gram-negative rods, anaerobic, right? So what we do is that I want to give a cell wall synthesis inhibitor and then a DNA gyrase to disrupt them. I hope you get it. Sorry, they are not gram-negative, they are anaerobic gram-positive. So if you want to give clarithromycin alone plus metronidazole, clarithromycin is not a cell wall synthesis inhibitor. I hope you understand that. So you need amoxicillin to break the cell wall so that other contents can enter inside the bacteria and kill it. I hope you understand that.
Yes, sir.
Yeah, so even in place of amoxicillin, we can go for cephalosporins, which are also cell wall synthesis inhibitors. So somebody want to give ceftriaxone or cefuroxime, but it is in extreme cases, but you should know that penicillins are more effective against Helicobacter than cephalosporins. So that is why it remains a constant. Are we there?
Okay. Yes, sir.
Good.
Sir,
Lydia, come on board.
can the amoxicillin be replaced with tetracycline?
Doxycycline. It can be an
Tetracycline.
attachment because doxycycline is also not a cell wall synthesis inhibitor.
Please, sir, I said tetracycline.
Tetracycline.
Yes, sir.
They are all tetracycline. We can add it to the therapy, but we don't use it to eliminate.
Okay.
Except when you are having, the patient may have gastric symptoms. You check and it's not Helicobacter pylori, but it can be any of the perfringens. That is when we do all the gram negatives. But when you test and it is H. pylori positive, it means we have a gram positive anaerobic there. So there should be a gram positive drug. So when you come to our hospital practice, some doctors want to mix these two and add doxycycline to it. There's nothing wrong. Because in the outskirts hospital, they don't even have the lab test to do a culture sensitivity for what do you call it? H. pylori. I hope you get it. So they are treating from all angles. But this is the best practice.
All right. Thank you, sir.
You're welcome. Lydia Kwao, come on board.
Hello, sir.
Yes, Lee. Just
Please,
Lee, come on
mine is the
board.
clarification on the peptic ulcer. Hello.
Yes, I'm listening.
Hello, sir. Please, can you hear me?
I can.
Please, mine is the clarification about the peptic ulcer and then the duodenal ulcer.
Yes.
Sir, please, you said with the the gastric ulcer rather. You said when the person is hungry.
No, when the
you have
person
no pain.
eats, that is when they have pain.
Yeah. And then the duodenal ulcer too.
When they are
you
hungry.
eat.
No,
When you
they
are
are
hungry, you have
interchanging it.
pain.
Gastric ulcer,
Okay.
when they eat, that is when they have pain. But
Okay.
duodenal ulcer, when they become hungry, that is when they have pain. So gastric
Okay.
ulcer is eating pain. Duodenal ulcer is hunger pain.
Okay. Thank you.
Welcome. Joseph, come on board. Joseph, come on board. Okay.
Sir,
Yes.
sir, thanks for your presentation. I just want to find out something. You know, we say NSAIDs they cause erosion to the gastric lining, so we don't give NSAIDs during peptic ulcer or in the treatment of peptic ulcer.
Yes.
So I want to find out the IM diclo and then the suppositories. Can it be given since it's not going directly into the stomach?
It is all going to work. You know, it's not direct stomach entry that is the problem. It is when it is absorbed and the liver distributes. That is when it triggers decrease in the mucus of the intestine. That is a thinning of the mucus layer. Already the mucus is thinning. And you want to give a drug which in 2 hours' time is going to cause severe thinning. That is why we don't try. So it's not just about the drug entering. When it is dissolving, the drug is not acidic. There is no problem. But after the capillaries and your lacteals have absorbed the drug and gotten distributed, that is when the problem starts. So for the NSAIDs, it's a big no.
Okay. Thank you very much.
You're welcome. Norbert, dude.
Thank you,
Dude,
sir.
that is my uncle's name. Yeah, dude.
Yeah. So my question has to do with the duodenal ulcer.
Yes.
Is it true that people with blood O positive are prone to duodenal ulcer? Thank you.
Not necessarily. It is only cholera that has been proven. For this one, it's still a hypothesis in which research is going on. But yes, they are seeing some cases, but it is not proven. It is only cholera that has been proven. I hope you are there.
Okay, sir.
So still they are researching.
Thank you.
Okay, Albert. Albert, we cannot hear you. Kindly reposition and get back to us. Joseph. Joseph. Okay, right.
Sorry, sir, I didn't lower my hand. I finished asking my question.
Okay, Razak, come on board.
Yes, sir. I wanted to ask a question.
Okay. Okay, we can't hear you well. Can you reposition, please?
Okay. I said I've come across a patient who came to the complaining of gastric pain, severe one. Within a short period of time, he blood of 3 pints. I've never seen somebody. He vomited almost 3 pints of blood.
Yes.
Instant.
Yes, it's true. What? That is peptic ulcer. Maybe the erosion might have, eroded a major artery supply or a vein supply in the stomach. So when that occurs, they bleed a lot. That is why we say that for severe cases, we have to transfuse. Because some of them, when the erosion erodes a major blood vessel, they may end up bleeding a lot of liters of blood from their body. I hope you get it. So yes, peptic ulcer can cause that. Albert, come on board.
Yes, my question is about, is there a rationale behind the gastric ulcer? The person experiences pain when eating, and then the duration the person experiencing the pain when hungry.
Okay, good. Yes. For gastric ulcer, there is an excavation there, right? And this patient has a sore in the stomach. Immediately they eat in food, the gastric glands begins to secrete what gastric juice and hydrochloric acid. When acid come into contact with a sore, what will happen? Pain. That's why gastric ulcer will come with what? Eating pain. But for duodenal ulcer, okay, when the gastric glands have closed, that place is a buffer zone for bases. But immediately the gastric gland is closed, base is not being secreted. So there is nothing like a buffer system. Meanwhile, the pancreas and ACE adjuvants will be secreting little bits of their secretions there. That triggers the pain there. And that is why we have eating pain in gastric ulcer and then hunger pain in duodenal ulcer. I hope you understand that.
Please, sir.
Good.
Thank you.
Judith.
Sir, please, we have peritonitis as an inflammation, as a complication of peptic ulcer. I want to know, is it the H. pylori that is causing the peritonitis?
No, the H. pylori can perforate the intestine. So when the intestine is perforated, contents of the lumen of the intestine may leak into the peritoneum. And when that occurs, the peritoneal cavity gets inflamed and it becomes peritonitis. Benson.
Please, you said the H. pylori will perforate the intestine.
Yes. When there's severe excavation by the acid, okay? When there's severe excavation, the hole or the soil is so bigger that it excavates. Sometimes the content of the stomach may begin to leak through that larger excavation into the peritoneal cavity. And when that occurs, peritonitis ensues. I hope you understand, Judith.
Yes, please.
Okay. Patients, come on board.
Okay, so going through your slides, you mentioned that the peptic ulcer mostly affect the duodenum than in the stomach. So I want more light on it.
We are saying that peptic ulcer will affect the duodenum, gastric ulcer. Peptic ulcer will affect the duodenum than it. Now listen to this. When you are done chiming, okay, the content of the stomach is released gradually into the duodenum. So it means the upper part of the gastric can, everything by gravity, as you are standing up, all the contents of your stomach are seeping down. I hope you understand that. So when that occurs and there's a constant opening into that place, it means the duodenum is active after you are done eating, but there are portions of your stomach which will not be active after you are done eating. So most of the time, it's the duodenum that is affected more in peptic ulcer than the gastric and the esophageal. I hope you get it. Patients, do you get what I'm saying?
Well, yes.
Okay, patient. Now watch what I'm drawing on the screen.
Okay.
This is somebody's stomach, okay? Assuming this is somebody's stomach. And there's a cardiac sphincter here. Now, if food comes in here, what happens is that the food will be lying up to this level, right? And this sphincter will be opening small, small, so that food can be passing down. So in that case, like the duodenum is going to be active with buffering systems. And that is why in most cases, you have the duodenum being affected by ulcers than the gastric gland. So because if you're not careful, there are even circumstances whereby the duodenum the stomach may even be almost empty, like this up to this point, but the duodenum will still be actively working to take contents from here. And that is why the duodenum is most affected. Do you understand it now?
Yes, sir.
Good.
Thank you.
Okay, Johnson.
So, in a treatment that we are talking about, I want to know is because of the amoxicillin is constant in the gastric ulcer treatment?
Yes.
Okay.
I didn't hear the question well, please.
So I want to know, in a treatment of a peptic ulcer, we
Yes.
realize that amoxicillin is constant.
Yes. It's because the
Yeah,
bacteria.
so I want to know whether it's because of
the bacteria is gram-positive anaerobic. We need a cell wall synthesis inhibitor to break the cell wall of the bacteria so that it can die and they'll be happy. So if you need a gram-positive, amoxicillins are more effective. You know the gram-positive, the cell wall synthesis inhibitors, they gave you 3 classes: bacitracin, astronam, cephalosporins, and all amoxicillins. They are all cell wall synthesis inhibitors, but amoxicillin is more effective. And that is why mostly we do it. But if it doesn't work, that's when we switch to cephalosporins. So the constant thing is that we need a cell wall synthesis inhibitor.
All right.
Are we there?
Yes, please. Thank you very much.
You're welcome. Catherine, we are doing question and answers up to 12:40. Then we switch to the next one. I know the topic is so interesting. Everybody wants to be well clarified, but let's go. When we reach 12:40, I'll switch to my next topic. That is pancreatitis. Catherine, come on board.
Sir, please. I learned that clients who experience gastric ulcers, they normally exhibit anorexia and nausea. But I want to find out, do clients with duodenal also experience the same thing? Duodenal ulcers.
They all experience the same thing. When there's any irritation along the GIT, it triggers the nausea and the vomiting symptoms. And we are talking about the upper GIT. So yes, the only difference is the pain. The pain, one is eating pain and one is hunger pain. Are we there?
Yes, sir. Thank you.
Okay. Patience.
So my question is about the medical management.
Okay.
You made us know about triple therapy, which is the PPI and 2 antibiotics. But I didn't get any quadruple therapy, please.
Quadruple therapy is triple therapy plus a bismuth or an antacid. So in that case, the triple plus something else.
Okay.
Do you understand that?
Thank you, sir.
Derek. Derek.
Good afternoon.
Good afternoon, Derek.
Sir, please, my question is this. Sir, please, my question is this. Given the anatomical position of the duodenum and the presence of the pyloric sphincter, how does duodenal ulcer cause epigastric pain?
The duodenum is also located inside the epigastric region. True or false? Do you remember the planes of the stomach, of the abdomen? You have the umbilical. So the duodenum is in the center point of the epigastric region, in the central point of the epigastric region. And so in that case, per the drawing, you are seeing it twisting and coming down. But the duodenum is not in the umbilical region. It is still in the epigastric region. And that is why it is all depicted as epigastric pain. In this case, we are not talking about left epigastric, right epigastric, no. Epigastric pain. Are we there now?
All right. Okay.
Good.
Okay, sir. Thank
okay,
you.
give tea.
Okay, sir, please.
Okay.
Sir, please, I read somewhere that ulcers are sores that do not heal. But I've also heard patients complain that they used to have ulcers, but they don't have it anymore. How true is that?
It heals. Anybody who says it doesn't heal is lying. It heals. Just that when there's a scar, it can easily be re-triggered. But there are people who develop scars that is fibrinated. So in that case, it doesn't get easily triggered. So yes, it does heal. Patience. As a whole, patience. Come on board.
Sorry, I've forgotten to put my hand, sir. I've asked.
Okay, give tea. Come on board.
Sir, please, you've answered it.
Okay, Atule.
Hello, sir.
Yes, Atule.
Hello. If you have ulcer in the duodenum at the same time in the stomach, can you term it as peptic ulcer?
Yes, it can.
Okay. Thank you, sir.
Brobe.
Okay, sir, please, in the quadruple therapy, it's 2 antibiotics, an antacid and an antispasmodic. Can we add an analgesic to it?
Brobe Ali praying.
Hello, sir.
Yes, Brobe.
Sir, please, I wanted to know if an analgesic can be added to the quadruple therapy.
Yes, you are seeing tramadol there. Have you seen it there? As other therapies. When you add tramadol, it's not quadruple, it becomes other spectrums, right? When I said analgesic, you can do para for mild pain, then tramadol for moderate, and then when it's so much severe, you can go for the petidins, right?
Okay, sir.
And I talk about the pain rating being from 0 to 10, whereby 5 is moderate pain, 10 is severe, and then 0 for no pain. So 1 to 3, mild, 4 to 6, moderate, and then 7 to 10, severe.
Okay.
You're welcome. Good. Emmanuel.
Yes, sir. Sir, my question is, we know the H. pylori is the causative organism that causes the ulcer. So I want to find out from ulcer.
You want to find out what?
But there is no presence of the H. pylori. I say a client is suffering from ulcer, but the organism, the H. pylori.
Wow. Please, we can't hear you. Can you reposition and get back to us, please?
And if it is yes, did we still say, I'm saying yeah. Can there be an instance whereby a client is suffering from ulcer, but the presence of the H. pylori is absent?
Yes, it's true. What we are saying, we said that H. pylori may be there in 70 or 90% cases.
Okay.
So there are 30% cases that is just NSAIDs and alcohol and smoking that brought it.
Okay. And then my question is, so if the H. pylori is absent, did we still need to use the triple therapy or the quadruple therapy to treat such cases?
No. So mostly when that occurs, we treat it as gastritis, a clinical knowledge, right?
Yes.
But yes, we are also allowed to add antibiotics because we are consuming things from our environment. And there's this belief that since there is an ulcer, it becomes an avenue attachment for normal flora, right? So in that case, we are allowed to do the antibiotics. But it's not always the time. So clinically, when there's no H. pylori, we treat it as gastritis, typically with antibiotics. But when there's H. pylori, then we diagnose it and then we add antibiotics. I hope you get it.
Okay, sir.
Okay, you're welcome. Let's go to Abubakar Kausar.
Sir, please, I wanted to know, in case of peritonitis, what is it a surgical case or?
It just becomes surgical. You have to see the surgeon
That's
to
where
close the
resection
hole.
and anastomosis take place.
Sometimes just not resection. It may just even be closing of the hole, right? And then doing paracentesis of the peritonitis. I hope you get it.
Okay, thank you.
You're welcome. Good. Abdullahi, Mustafa. Mustafa is not there. Reku Benson. Benson.
Yes, sir. Good afternoon.
Good afternoon.
Yes. Please. I want to find out, is there something like stress ulcer?
Sometimes when the cause is noted to be stress, then medically we term it as stress ulcer. Like we just want to say that yes, this person has ulcer and that the cause was stress, but it's still peptic ulcer. Just that people medically we use certain terms like when we say sickler, there's nothing like a sickler patient. I hope you get it. So it's that same jargon that we use and say stress ulcer. I hope you get it. But they are all peptic ulcers.
Okay.
Okay,
And
Eric.
I noticed.
Okay, go on, Benson.
Yes. In the case of tumor of the stomach, I heard those people hardly get ulcer. Is it true?
It is not. It is not. It's just a postulate. There are people whose tumors also trigger severe ulcers along the whole GI. So it is still not true. It's just rumored and being postulated. I hope you are there.
Yes, please.
Okay. So let's get the next person on board. Eric.
Yes, sir. Good afternoon.
Good afternoon, Eric.
Sir, please, in my facility, let's say in a health center, then a patient come with like early sizes.
Okay.
With severe pain.
Yes.
Sir.
Yes,
Hello?
I'm listening.
With severe pain, then with the other therapy like the tramadol. Is it advisable for you to give tramadol to subside the pain, or is there any other alternative?
For pregnant women, we do normally our PMO, right? You mostly want to do paracetamol.
With severe pain.
With severe pain, yes. You want to just give the paracetamol, then we give our new gels. In the hope that the what do you call it? In the hope that an analgesic within new gel will have the capability of subsiding the pain directly from the site. When that the new gel becomes a local anesthetic. You know, new gel has a local anesthetic agent. So that is what we do. Give them paracetamol, give them new gel to go so that locally it can work on it directly. You don't want to give them systemic drugs, except you refer to the obstetric and gynecologist to handle it from there, right?
Yeah, so but the issue that I've witnessed a case like that, and then they've ordered a TM tramadol 100 milligram to be infused in the ringes for that early sizes woman.
It is dangerous, very, very dangerous. I don't think was a doctor an obstetric and gynecologist.
No, please.
Did you have a fetal monitoring kit, electronic, Sonic and CODeL? No,
yes,
you don't try. You refer to an ONG to handle when it is severe. So most of them, when we are giving them PPIs, we don't let them buy the normal omeprazole. You know, esomeprazole is expensive. So rather we put them on antacid, then we let them buy esomeprazole for 14 days. So that by ESO is expensive, but within 2 weeks, they'll be fine and they are happy and we are all happy. But to go for tramadol is quite dangerous, except when there is an obstetrician available, so that in case there's any complication, they can avert. Okay?
Okay.
Hello, sir.
Yes.
Please, sorry to interrupt. I wanted to ask him if those medications were given before laboratory investigations or what?
He said they knew. They knew that she was pregnant yesterday. They gave tramadol, which is dangerous.
Okay, sir. Thank you very much.
Yeah. So, Grace, we have just 4 minutes and we are done with this chapter. Grace, come on board.
Okay, sir. Please, I would like to ask if a H2 receptor antagonists are also used to treat ulcers.
For pregnant women, we don't try it.
Okay.
Yes, H2 receptor, they are second line drugs, like cimetidine and ranitidine. I think we talked about them last week, right? You can use them, but they are like a second line. But in most cases, the first line is able to treat it, so we don't go there, right?
Okay.
But when it becomes so chronic that we are doing everything, it's not working, we put people on H2 receptor antagonist, okay?
Okay, thank you.
Good. Let's go to Asara. Isao Asara.
Hello, sir.
Yes.
Please, you were making a point and then my network jumped up. Someone asked a question concerning not giving NSAIDs to a PUD patient, but rather giving IM diclo also. Then you made mention of the fact that it is about the liver absorbing and distributing. So that was where my network jumped up.
Yes, we are saying that for NSAIDs, it's a big no. It's not the local effect of the drug. NSAID is going to come with a systemic effect, which is thinning of the GIT's mucous protective membrane. So if you are giving it whether IM or whether you are giving it by suppository, it's still going to be absorbed, sent to the liver for first pass effect, and then redistributed. So the adverse effect is going to be experienced. So no, a very big no. Okay. Okay, we take last two questions, then we continue with our week. When we are done, then we take next round. So from it, we come to a Gifty. Gifty. Gifty, come on board.
Say, please, I heard that those with the duodenal ulcer, they normally gain weight, while those with gastric ulcer, they normally lose weight. So I want to find out how true
Yes,
is
it
it.
is true. For them, when they have pain, they want to eat so that the pain can go down. So as you are eating more food, you'll be producing a lot of excess glucose in your body. Insulin will be converted into glycogen. Then glycogen will be converted from the liver into what? Under your skin as adipose tissues, right? So the more you eat, the more weight you gain. But people with gastric ulcer, when they eat, they have pain, so they don't like food. So they rather grow lean. While those with duodenal ulcer will grow bigger, right? So yes, it's true. Ebenezer, please mute your microphones. Ebenezer, come on board.
Sir, please, does change in diet help in the management of peptic ulcer?
Yes, I mentioned that reduce spicy food, less caffeinated, avoidance of alcohol, and irritants. So yes. Income, Jessica. Jesse, come on board.
Hello, sir.
Yes.
Please, you said that hydrochloric acid in our stomach helps in the digestion of our food substances. I would want to know if it's the same acid causing the ulcer or there is an external acid.
It's the same acid. It's the same acid. Just that with peptic ulcer, the mucous membrane that is protecting the surface of the stomach is lost. So the acid will now be moving directly into the skin or the mucosa, right? And that is when the ulcer comes in.
Okay, thank you, sir.
You are welcome. Then the last one, Asante Danswinok.
Thank you, sir. Please, at what stage would anti-inflammatory drugs be needed, and also any mucosal healing drugs?
When we do second lines, like quadruple therapies, and they are not working, in that case, we go broader to an extent of adding antispasmodics, painkillers, mucosal healing drugs. They are even extend that we go and they would do what we call fundoplasties, that is surgical management. So when your first two lines are not working, that is when we refer to a gastroenterologist to now continue from there.
Okay, thank you.
You are welcome. So with this, I think we have elapsed our time. There are new members joining to ask questions. kindly note them and reserve them so that as we go forward, we just come on it and then we treat it. So this one, I'll do pancreatitis as fast as possible, and then we take it out from there. Okay. Okay. Sorry, I think my phone is really giving me some tough times. I think I have to go and buy a new phone. Wow. Hello? Please, can you see what I have on the screen?
Yes, sir.
Yes, sir.
Yes,
Okay.
sir.
Yes,
So we take it
please.
out from you. I want to treat pancreatitis. Pancreatitis, that is a condition of the pancreas. Inflammation, when the pancreas is inflamed, pancreatitis. In fact, this condition is killing a lot of people. And most of the time, by the time we realize that they have it, it is almost impossible to treat it. So like we all know, the pancreas is a granular gland that is located in the deep abdomen. We know that the pancreas has both endocrine and exocrine functions. That is, when we say exocrine, secretion of pancreatic juice. Endocrine, secretion of what? Insulin, right? And I all know that alpha, so we're treating this as a full topic this semester. Endocrine systems after these GIT, so don't worry. So you can see the pancreas there like you all know already, right? Yeah. So I think it becomes easy. What is pancreatitis about? It's just an inflammation of the pancreas, just like that. An inflammation of the pancreas. In fact, the actual mechanism of pancreatitis is unknown, but it is believed that it's a lot of autodigestion of the pancreas that causes it, because in most pancreatitis, when you discover it and it's not treated early with drugs that will reverse the destruction, the pancreas will continue to digest itself until it is totally destroyed. And that's why autoimmune or autodigestion is a major known cause. In fact, pancreatitis can be chronic or acute. And that if whether, what do you call it, acute or chronic, it requires adequate, appropriate medical care because it is very life-threatening. In fact, if you have it and you are not careful, you delay, by the time you realize, your poster will be coming on TikTok with Mama Esther's song playing. I mean, if I won't see Jojo, right? So what is it about acute pancreatitis? You are saying acute pancreatitis is life-threatening by reversible medical condition. But the chronic one is not reversible. That is why it kills. And funny enough, most acute pancreatitis, if not discovered early, will transverse into chronic pancreatitis and then become quite more dangerous. And that is why it has to be treated with adequate care. In fact, what are the main causes of pancreatitis? First, gallstones, and then heavy alcohol consumption. So those who enjoy themselves overly during Christmas, if you are not careful, you should be getting ready for trouble, right? With alcohol. Then Nana Bobi Ansa and then Kwame Bobi people, right? And then what about drugs? Azathioprine is known to trigger pancreatitis. Sulfonamide, such as sulfadoxine, pyrimethamine, SP, such as sulfamethoxazole, such as dapsones, they are all known to cause it, as well as steroids, like the macho men who want to take dexamethasone, prednisolone, and co to look like Mr. Ghana, right? When they consume steroids too, they become prone. Also infections, such as any other bacterial infection of the pancreas, and then it can also be viral, that is mumps. So when mumps attack people, it's so dangerous that it can trigger orchitis and make you impotent when you grow older. If you are also not careful, the mumps virus can enter the pancreas and then cause pancreatitis. Blunt abdominal trauma, like these boxers who wear gloves and people be punching directly at the abdomen, right? In the name of training. In fact, certain things are only for Chinese movies. Don't go and stand there and open your shirt and tell people that you can sustain blows from people and that you have miracle. Don't try it before you blow your pancreas. And also idiopathic. Sometimes the cause is unknown. They are quite decent people. If I went to open YouTube, you see a lot of documentary doctors who have had chronic pancreatitis. And they will tell them that they have 6 weeks to go. And then you are seeing that, the doctor will go to work, they will give them the line of salute. You'll be with his family for some time, and he died in 6 weeks' time. So typically, please mute your microphone. So typically, the cause of pancreatitis can be idiopathic. That is unknown. What is the pathophysiology? In fact, the main cause is unknown, but this is what we think might be causing it. One, so that all the acute pancreatitis is multifactorial. The disease mostly begins with gallstone formation. That is when there's a stone in the bowel. That is the bowel that the stone blocks it. So that the gallstone then enters the common bowel that enlarges in the ampulla of Vata. When you look at the anatomy that I showed you earlier on of the pancreas, you can see the valve of Vata here. Okay, you can see this hole there, right? Let me just give you a drawing. So you see that the gallbladder is bringing its stones from here, right? You can see the cystic duct and the bowel duct. And you also have the pancreatic duct coming here, right? Now this is what we call the valve of the Vata. So this is a hole here. This is where the two ducts open into the duodenum, right? And that per the physiology, we are saying that the gallstones, after being formed, can get dislodged. Oh, I just lost my screen again. Sorry. Oh. So per anatomy that I'm showing on the screen, we are saying that the gallstone can get dislodged from the bowel duct into the what? The Vata. And when that occurs, we are saying that this results in obstruction, resulting in overflow of pancreatic juice. So per the anatomy that you have in there, you realize that when it is blocked, when this hole, this opening is blocked, let me show you the opening. That is when this opening is blocked. What happened is that pancreatic juice, which is supposed to flow through the pancreatic duct down here into the duodenum, is blocked. So when it is blocked like that, it's going to lead to what? A blockade and then a flow back of pancreatic juice into the pancreas. So when this occurs, then we say that, oh, my screen, sorry. I think I have to buy a new phone this week. My phone is not being helpful. So we are saying that when that occurs and there's a blockade, that this results in obstruction, resulting in the flow or in the backflow of pancreatic juice or bile. Eventually, there's a flashback of pancreatic juice. The reflux activates release of pancreatic enzymes, leading to autodigestion. The autodigestion results in inflammation of the pancreas with subsequent erosion and necrosis. So like I explained, when that valve is blocked, what happens is that there's going to be backflow into the pancreas. Then the pancreas will react by releasing these enzymes, so because it will see the reflow as foreign bodies. As the pancreas is trying to attack, it will start attacking its own cells. And when the cells of the pancreas are attacked, we are saying that it leads to what? Erosion and what? Necrosis. And when that occurs, inflammation, they will say that they have pancreatitis. So, what are the clinical manifestations? It comes with severe upper abdominal pain, which may radiate to the back. Somebody will ask the radiation to the back. Yes, peptic ulcer also sometimes radiate to the back. But for pancreatitis, the pain feels like a back pain. It also feels like a frontal abdominal pain. It is going to come with abdominal distension. And that distension is always upper abdomen. Like, you know where the pancreas, so you see an abdomen, you know, for all abdomens, the lower portion is supposed to be the one protruding. But pancreatitis, you see the upper part protruding upper, then the lower portion being flat. When that okay, we say that there's guarding. Like when you say guarding is like formation of a guard, like a round object around your heart, your epigastric area. Also, it leads to tenderness. When you try touching, it comes with severe bounding pains. There may be nausea and vomiting, and there may also be fever. How do we diagnose? We do serum analysis, history taking. Also, we do serum amylase and serum lipase. Why? Pancreatic juice contains amylase and what? Lipase. And that's when people have pancreatitis and there's backflow. What happens is that the entire circulation is choked. And that lipase may begin to go down. Serum lipase may begin to go down. So when you test it, you see it looking very low. You realize that no, it seems the pancreas is not working well. That is why we do serum amylase and what? Lipase levels. Also, we do full blood count. What will full blood count show us? It is going to give us, if it is bacterially, like it has bacteria so it is of bacterial source, white blood count to go high, lymphocyte and everything will go high. So when it's viral, lymphocyte go high. Granulocyte will go high in bacterial infections. We do stool array. Why? When we test the stool, sometimes you realize that there are no remnants of pancreatic juice there. And stool array is also going to show you a lot of undigested food molecules because digestion of protein will not be complete. Digestion of glucose will not be complete. We do abdominal CT scan as well as ultrasound to measure the size of the pancreas. How do we treat it medically? We just hydrate them by giving a lot of fluids. Then we put the patient on nail per os. Why nail per os? Even when they eat, there's no pancreatic juice to undertake digestion inside the duodenum. So if patients keep on eating, the pain keeps getting more and more. So that's why we keep patients on nail per os, and then we give them fluids. Also, we give them drugs such as analgesics, and that at times we may have to pass nasogastric tube to remove contents of the gastric gland, or an NG tube can also be used to pass into the duodenum area so that food can pass across. But most of the time, we use the NG tube to do gastric lavage. That is to empty every content from the stomach. Lesson-wise, how do we care for them? We do psychotherapy to release stress. We want them to calm down. Reassure them and explain all our procedures to them. We do IV therapy according to their needs. And that we are sometimes even tempted to give total parenteral nutrition. I think you all know what TPN is, right? That is whereby the entire food and nutrient need, like high protein, selenium, those working at the teaching hospitals and regional hospitals, I know you know these infusions, which is nutrition that is being given by what? IV. Sometimes we encourage them to take only more fluids. That is PRN. When the also has not been indicated, you let them take enough fluids so that the stone, the gallstone can emulsify. Because immediately the stone emulsifies, it helps in the healing process. You monitor them for vital signs. Also monitor their sugar levels. Why? The pancreas is corroding off. And that in that regard, the endocrine function of the pancreas is going to get compromised. And when that occurs, it means the pancreas the beta cells will not be working, insulin will not be produced, and so glucose regulation becomes a problem. So most people with pancreatitis will have a lot of glucose fluctuations. Please mute your microphones, please. Also, we monitor intake and output to assess their level of dehydration. And that most of them, we put them on LPS. Please mute your microphones, please. For diet, we put them on LPS. But when they can tolerate some food, we avoid heavy meals. We give them very soft meals. We serve them with low fat and protein diet because we know that they cannot digest the protein and then the fat in there. We also encourage them to avoid alcoholic beverages. Medication, we just give when it is indicated as bacteria of nature, we give antibiotics. We can give antiviral agents. We can give immune boosters. Or sometimes we give immune suppressants too. When it is known to be autoimmune, there are immune suppressants that we give so that the immune system can calm down and avoid digesting its own pancreas. And then after giving the drug, we monitor for its therapeutic as well as adverse drug effects. You should know, we don't monitor for side effects of drug. Side effects are normal. The only monitoring is that of the adverse effects. In fact, when pancreatitis is left untreated, what even happens? One, there may be diabetes mellitus, like I said. Because when the pancreas is digesting itself, consequentially, you're going to have inadequate production of insulin. When insulin is not being produced, it means blood glucose regulation becomes an issue, so diabetes mellitus. Malnutrition, why? Their instant pancreatic amylase, lipase, and tryptase may not be produced. So digestion of glucose becomes an issue. Final digestion of protein is an issue, as well as final digestion of fatty acids and glycerols. And that if pancreatic acute become chronic and the chronic is left untreated, it may become pancreatic ulcer, pancreatic cancer, which is irreversible. Nearly you reach this stage, no matter what you do, you die because we don't do pancreatic transplant. It has never been done. So for now, if you have any issue with it, you should be getting ready to go and then allow the remaining population to enjoy the banku. So with this, let's come and hold a discussion. Let's hear your concerns, contributions. Okay. Okay. Let's see the chat. Some people have sent messages. Okay. Good. Mustafa, come on board. Mustafa, please come on board. Albert, come on board. Mustafa is not ready. Albert, come on board. Oh, Albert, I can't hear you. Can you reposition and get back to us, please? Actually, come on board.
Please, sir. Hello.
Yes.
I was once told that when you have a ulcer syndrome, to do a lab test to reveal that there's H. pylori. It does not actually mean that you have ulcer, but the most reliable means of diagnosing ulcer is endoscopy.
Yes, that is the best way. Yes, it's true. That is the best way. By most instances, clinically, I think I live in Kumasi here. The hospitals that can do endoscopy here in Kumasi are not up to 5. We are talking about a population of 6 million. So that's why when I said clinically, in most instances, for that H. pylori, we treat it as gastritis. When H. pylori is indicated, we treat it just as a general ulcer. But when we do our first and second line is not working, that is when we let the patient go to do endoscopy. And that becomes the final say. I hope you understand that. Atula, are you with me?
Thank you, sir. I've heard you.
Okay, good. So, Albert, come on board.
Please, I want to know whether
Albert, we can't hear you. Your line is breaking. Kindly reposition and get back to us, Albert.
Okay.
Kausa, come on board.
Okay, sir, please. Does people with diabetic mellitus are higher risk of having the pancreatitis? And does genetic involves and obesity?
Okay. For pancreatitis, people with diabetes being at high risk is a big no. Okay. People with pancreatitis will rather be at a higher risk of developing diabetes mellitus. And yes, for all cancers and some of these, they are genetic predispositions. So yes. Counselor, I hope you are answered.
Yes, sir.
Okay. So maybe I'll come on board. Mabel.
Yeah, please, about the administration of IM diclofenac in ulcer patients. Yesterday, we learned in pharmacology that drugs that passes through first pass metabolism are drugs taken orally and then anally only. So I got confused with the explanation.
The explanation we are saying is that for diclofenac in ulcer, okay, it is not about the drug molecular nature as of the time of administration, but it is after it has been distributed. And the general side effect of it is that it leads to thinning of the mucus of the general GIT after it has been distributed in your blood. The columnar cells of your GIT will react to it by thinning their mucus. So it's not necessarily about you taking it orally or anally. It's about the drug getting in your blood and your cells responding. So in that regard, if somebody has ulcer and want to give an NSAID, it's not necessarily about the drug passing through the intestine. It's about the after distribution effect. And that is why it is a big no to give them in gastric ulcers. Because in that case, it's not about the drug passing through like an antacid. No, it is rather about the after distribution effect. Are we there?
Yeah, thank you.
You're welcome. Eben. Adongo Ebenezer, come on board.
Sir, I got confused about the amylase and the lipase level in the serum.
Yes.
When one is having pancreatitis, is it that it will increase or it will decrease?
It will increase.
Okay, thank you, sir.
It will increase, okay?
Okay.
Mahama Aziz, come on board. Aziz Mahama, come on board. Hello, Mahama, are you there?
Yeah.
You hold a presidential name, so ask us presidential questions. Oh, Mahama, we can't hear you. Okay, Abigail Nkitia, come on board. Abigail, come on board.
Hello, sir.
Yes, Abby.
Sir, please, is it advisable for pregnant women to continue taking SP since they can get pancreatitis?
Yes, it's advisable. It is advisable, okay? It's people who take sulfur for protracted period. SP is taken once, and after a longer time, you come and take another one. You're talking about people who are taking sulfur drugs for like TID and KYD, okay?
Okay. Thank you.
Okay, Edward.
Okay, sir. Thank you very much. Please, I want to know, since there will be impairment in the production of insulin by the organ, can we initiate let me say diabetes mellitus treatment, especially the insulin-dependent type of diabetes?
Yes, in most pancreatitis, we manage glucose as well, especially the chronic ones. For almost all chronic pancreatitis, they also have diabetes mellitus type 1. So, yes. Edward, are you answered?
Yes, sir.
Okay. Rashid Khalid.
Yes, sir. Please, I wanted to know the difference between the radiation of the back, the pain, abdominal pain radiation to the back in pancreatitis and that of peptic ulcer. Like, how are we going to differentiate it?
Okay, the differentiation is that for pancreatitis, it's come with Gordon, like Gordon. You know what a GARD is, right?
Yes, please.
So for pancreatitis, you see a GARD on the upper, what do you call it, epigastric area. You see a GARD there. And then there's a pain radiating to the back. Immediately you see those two signs, you know that you're dealing with pancreatitis. Okay. But for peptic ulcer, there's radiation, all right, there's tenderness, but there's no GARDing.
Okay. So thank you.
I hope you understand that.
Yes. Thank you.
Oh, you're welcome. So, I think Deborah, Boatin.
Yes, at NTC, I learned that they have a clay colored too, but I didn't understand why it is so. So I wanted to know if it is true.
No, clay colours tool is not with these pancreas, rather with people with dysentery. Dysentery. Okay?
Okay.
Start cholera and dysentery. We're talking about rice water stools, clay colours tools, right?
All right.
Okay. Rukaya. Rukaya Razak.
It's about the
Please, we can't hear you well.
It's about the...
Yes, go on. We can hear now.
When you say we can use
okay,
the
please,
tramadol,
and get back to
I was asking, can we give Buscopan?
Yes, we can give Buscopan. When we talk about the other therapies, we also added Buscopan, okay? So yes, we can give Buscopan. After quadruple therapy, there are other therapies whereby I indicated Buscopan, okay? Wow, okay, we can't hear you well. Your voice is so scratchy. Kindly reposition and get back to us, okay? Mustafa Abdullahi. Mustafa Abdullahi, get back to us. Mustafa Abdullahi. Benedict. I cannot mention the other names. Benedict.
Okay, sir, please, can there be a situation where they notice the gallbladder area and then do a surgery and remove it?
Yes, they are able to. They are able to, but it's very more common people who go for checkups. Like some of us who have been eating Banku KYD and eating pork and dog meat every day without going to the hospital. By the time they discover you are in trouble. But if you go for checkups, yes, it can be noticed. Please, Benedict, can you mention your full name?
Golomeke Ram Bernadette.
Hey, mention again.
Golomeke Ram Bernadette.
Okay, Golomeke Ram Benedict. Okay, I'll note that name. It looks like your money sounds like somebody with a lot of money in their bank account, right? So don't worry, I'll be your friend. Amen. Ebenezer.
Yeah. Please, concerning the question that was asked about the clay colors too.
Yes.
I think it will be there because we know that the pancreas produces as the
No, it's a
gallbladder,
gallbladder. You are talking about the gallbladder, yes?
yes, that stores and release the bile,
Yes.
emulsify the fat. It's the bile that also gives the color at times of the stool. So if
Okay.
it's blocked and it's not able to release the bile to emulsify the fat and on to digest the food, other food components, then I think at the end of the day, the stool color will be the clay color.
Okay. Now listen to this. It used to be that, but they gave an update saying that there are times that the stone, when it is flashing back, it doesn't block the guy. It may go back and block only the pancreatic duct. It also occurs like that. So they indicated that when there's a clay color stool, it should not just be associated with pancreatitis. I hope you understand that. It used to be, but now they updated and said, no, if you look at Bruno and Sadat, I think is it the 16th version, they've taken it off and then they have their video explanations. Are we there now?
Yes, sir. Thank you very much.
Okay. Last question from Edward. Edward. I can't see the chats. I can see people have sent chats, but it's not open. I don't know. Whoa, so there are like 300 of us in this class. That is a mass class. And there are backing vocalists somewhere. I can see Susie, Asiedu, Stella, Tufo. Hayford has never asked me a question. Samuel has never asked one. Veronica Moses has never asked one. For Rekun is my friend. Felix is there. Kumsin has asked questions. Jackson Kwatin Opoku has never asked. And it's for Rahina too.
Sir,
Yes.
please, can you help me with this and how the pathophysiology of gallbladder causing the pancreatitis? The way you were explaining, I didn't get it well. So if you can just please recap on that one for me.
Let me say I was waiting for you. Okay. So on a quick one, okay, we have something that we call bile stones, right? And that they are stones that are formed as a result of over-concentration of the bile inside the gallbladder. And that when they stay there, they are excessively concentrated.
They are formed as a result of
highly concentrated bile salts. It's bile salts. In fact, bile is not just called bile, they are called bile salts. But when there are excessive concentrations of them, they begin to crystallize and form precipitates. And when they crystallize, bile is supposed to be secreted through the common bile duct, right? Into the ampulla of vata, so that it joins the common bile duct, and then it emulsifies fat inside the small intestines. Now this is the case. As it is, sometimes the stones can be so big that when they reach the ampulla of vata, in which I showed during the slides, right? Let me show you again. When they reach the ampulla of vata, instead of getting released into the duodenum, they just stay there, here, just at this place, this whole opening there. So as they come from up, they will come and then they will block that hole. And when they block the hole, that is the ampulla of vata, or this place, I think here, this is where they block. So when it blocks, it means all flows that are coming from the pancreatic duct and the bile duct get retained behind. And when they retain behind, we are saying that they get flashed back. They get flashed back. And as they are being flashed back, now the pancreas will see its content being brought back to it. But instead of storing it, it doesn't have storage. So it is going to see the flashback as what? As a foreign body. Then it begins to attack it. Like as there's this backflow here, right? Like let's say when there's backflow here, they will go into the pancreas. The pancreas will see it as foreign body. It will start attacking it. And as it's attacking itself, it will lead to what? Corrosion. And as it is corroding itself, it becomes necrosed. And then inflammation sets in, forming the pancreatitis. I hope you are there now. Also, are we there?
Please, I understood. It's like the calcium calculi in the urinary tract. As is blocked.
It's the same method. It's the same thing. Okay. It's just the same thing. So I'm now seeing Ali, Tukata, Enoch. Yes, I'm seeing new people. Ali, come on board.
Sir, I want to know the incident rate between talking about pancreatitis. I want to know the incidence. Does it affect women more than men, or it affects men more than women?
For now, pancreatitis is being studied, but they say it affects more men than women, according to the current postulate. But they don't have exact figures. So when you read on it, they don't give so much incidence. There are some people who are saying, it affects more men than women. Or we don't know whether it's affecting Black Americans or Black Africans more.
Okay, sir.
But more men are known to have it because we are the one who smoke and drink a lot, right?
Okay, sir. Thank you very much.
Adongo Mercy. Adongo, please come on board.
Sir, we know that the pancreas produces the enzyme. So
Yes.
is there an instance when the enzymes are not able to come out because of the blockade or because of any activations, they start to digest the pancreas itself?
The enzymes are not supposed to have the pancreatic juice inside the pancreas. The juice is supposed to pass through the duct and go away. But when they are retained, the pancreas gets choked, and then the enzyme will see its own secretions as foreign body. So when that occurs, it gets activated, then it begins to attack and then feed, forgetting that it is its own cells and organs. So when it attacks, it destroys its own cells. You understand that now?
Yes, please.
Okay, good. Judith. Judith.
Sir, please, since there is obstruction at the common bowel duct, I want to know the effects on the bowel. Is it because you are handling pancreatitis? That's why you didn't mention that.
Okay. Most of the time, we are not saying it doesn't block the common bowel duct. It blocks the vasa, the vata, the ampulla of vata, right?
Sorry, that
that is when most of the blockade occurs. Bile will be secreted, but the bile will be joining the pancreatic juice back into the pancreas. I hope you understand that. So when you start jaundice too, I explained to you the mechanism of bile. Sometimes there could be jaundice, but for most pancreatitis, there's no jaundice. It's rather the pancreas organ itself that becomes jaundiced. Are we there?
And so that means the bile is able to
secrete
flow.
Small quantities, but they all seep back into the pancreas.
Oh, okay.
Because the common bile duct has 3 valves along the line. So backflow is always very difficult. I hope you understand that. Okay. Diana. Diana, please come on board.
Sir, hello, good. Hello, sir.
Yes. Good afternoon.
Hello.
Yes, Diana, come on board.
Hello, sir.
Yes, Diana.
Hello. With the signs and symptoms, I learned there's some rashes.
It's not classical. It is not classical. Is it the rose spots? Rose spots maybe as a result of reaction to bacteria. It can be as a result of excessive bile on the skin, but it is not classical. They are secondary.
Oh, okay. So we can't add to the signs and symptoms.
No, they are secondary.
All right. Thank you.
Twinkle. Twinkle.
Sir, flatulence.
Please, we can't hear you. Can you reposition and get back to us, please? Kindly assist us. Emmanuel Adams, come on board.
Yes, sir. I just want to seek clarification concerning the clay-colored stool.
Yes.
With your explanation, does it mean that the gallstone could block the pancreatic duct instead of the ampulla of Vita?
There are instances.
Oh, okay.
It's mostly ampulla of Vita, but there are instances, okay?
Okay.
Yeah.
Thank you.
Prince Broby.
Okay, sir. Please, structurally, I see the duct from the gallbladder and that of the pancreas smaller than the junction where they meet. So my confusion is, how will something that leaves a smaller, say, lumen come and block a larger area?
Okay, there's something that we call precipitation. Have you heard of it before? Precipitation. As it travels, it may be a small particle, but as it's joining the common bile duct to the ampullae, there may be other, what do you call it, cations joining, which may precipitate and make it become bigger. When it becomes bigger, it is definitely capable of blocking, because the ampulla of Vita also have a valve there that controls the opening and closing. Are we there? So there are instances that small particle, by the time the ampulla of Vita has formed precipitates and become bigger. Is that understandable now?
Yes, sir.
Okay. So who else? Sarah. Yes, I was waiting for Sarah. Sarah Benton, where's Antoinette? Yes, Sarah.
Please, with the causes of pancreatitis, from what we've learned, I think the actual cause of it is unknown, but the rest are predisposing factors. I just want to clarify whether that one is true.
Sometimes there are actual causes, and sometimes the cause is unknown.
Oh, okay.
Are we there?
Okay.
Sometimes there are actual causes. The main cause is unknown, what may be triggering, but we have now come to realize that yes, there are other factors that may predispose it. And that at times you do your own laboratory examinations and you're able to see that indeed this is what is happening. But most of the time, yes, idiopathic. But there are times you're able to note the stones there.
Okay.
Are we there? Yeah.
Yes.
And even there are times that the valve at the ampulla of Vita can also be constricted. You know what I was saying? I said that let's take one of the pathways, and one of the major pathways was the stones. But there are times even the ampulla of Vita may be constricted. There are instances it's also okay. That's what they are saying, that it's mostly fatal. When it attacks you, you may be putting yourself in trouble.
Okay. Thank you very much.
Yes. Antoinette. Antoinette.
Yeah, hello, sir.
Yes.
Please, my question is, are there specific nutritional interventions to prevent excavation of the pancreatitis?
No, please. Just drink water.
Okay.
You want to emulsify the contents. You just want to emulsify everything in your body, so drink more water. That's the most important thing. Then
Okay.
low-fat diet, low-protein diet. We are done.
Okay, sir. Thank you very much.
Johnson. Nanewoto.
Yes, sir. So I want to know whether pancreatitis that prevent the production of
I can hear you
insulin.
well.
Please, can you hear me?
Yeah, I can hear you now.
Yeah. I want to know pancreatitis that prevent the production of insulin.
Like the pancreas, the pancreatic cells itself that produce the insulin. Yes, the beta cells produces the insulin, right?
Okay.
And
no,
so if the
So I want to know whether it will prevent the pancreatitis will prevent the production of the insulin.
Yes, when the autoimmune system is autoimmune and corroding its own self, yes, it destroys the entire cells and necroses them. Beta cells are also part of the cells, isn't it? So automatically, insulin production gets compromised. That's why we are saying in most of the time, for most chronic pancreatitis, as you treat it, you also do diabetes mellitus management.
Okay. Thank you very much.
You're welcome.
Yeah.
Sarah Azan.
Sorry, sir. Sorry to chip in this. Sorry, sir.
Yes, I'm listening. Benson.
Sir, with a follow-up question to what my brother just asked. I also noticed that diabetes mellitus people, it is in a rare difficult, or should I say it's a rare case, they also get chronic pancreatitis. So I don't know if there is a relation to that.
For most diabetes mellitus, we want to know whether you're dealing with type 1 or 2, and that it may be your clinical experience. But for now, rather pancreatitis will bring about, diabetes mellitus. But as to diabetes mellitus triggering pancreatitis is extra secondary. But almost all pancreatitis are going to lead to diabetes mellitus. But diabetes mellitus doesn't lead to pancreatitis. It may be a clinical coincidence with high frequency. Do you understand that?
Yes.
Hello, Benson.
Yes, sir.
So what we are saying is that almost all pancreatitis are going to lead to diabetes mellitus. But diabetes mellitus leading to pancreatitis can be a clinical coincidence, yes, but it is not on the high ascendance. So when we are doing clinical like this, we don't add it. I hope you understand that. Okay.
Thank you.
Sarah.
Sir, please, can pancreatitis affect children?
Yes, it can. Autoimmune. So when your immune system is so strong, yes, it can. Richard.
Yeah, sir, please, can pancreatitis leads to a chronic one? Can it lead to anemia?
Chronic pancreatitis to anemia. It can be secondary, but not primary. So it's not part of the complications, okay? Hello?
Thank you.
Chronic pancreatitis can lead to diabetes mellitus, which can lead to chronic kidney disease, and then chronic kidney disease will lead to anemia. But it's a longer pathway, so it is not a direct complication.
Okay, thank you.
Razak Rukaya.
So diabetes mellitus is the same as pre-diabetes.
Okay, please, we can't hear you. Come again.
So I'm saying that it's the same as pre-diabetes.
Wow, we can't hear you. Kindly reposition and get back to us, okay? Or type your question so that we...
Please, can you hear me?
I can hear you now.
I was asking that diabetes mellitus as pre-diabetes.
Wow, it's still cutting. I can't get you well. Kindly type it onto the chat session, okay?
Okay.
Okay. And you agree, John.
Please, can the sickle cell disease lead to pancreatitis?
Sometimes, yes. Autoimmune issues, yes. I've seen a couple of pancreatitis that the patient has sickle cell disease, but like my brother was also saying, we cannot make it as a direct correlation. There can be immune issues. Since we are saying that it's autoimmune, yes, it is possible.
Okay, thank you.
Yeah. Francisca.
Sir, please, I want to ask. I managed a patient with pancreatitis, and then it got to a time that the patient he started getting jaundice. So I don't know if there is any way you can help me with that.
Yes, like another person was saying, and I was like, when you manage pancreatitis, right? When they blockade, the gallbladder is going to keep releasing bile small into the common bile that then it gets pushed back into what do you call it? Into the pancreas. But there are instances whereby the gallbladder is full. So when it is full, automatically it means there's inadequate storage for bile. So when there's inadequate storage for bile, what will happen? Now the bilirubin will begin to move underneath our skin, and then they will land under our conjunctiva and sclera. They begin to see yellowish discoloration of the skin. And that is why it becomes an obstructive jaundice, right? So yes, it is there, but it is a secondary complication.
Okay, thank you.
Good. You are welcome. I guess we are done. Let's take Constance. Constance, come on board.
Sir, please, can tinnitus be a complication of pancreatitis?
Tinnitus will only come in after the patients had had tinnitus, right?
No, pseudocyst.
Pseudocyst.
Yes.
Not
It's
really.
a collection.
Yes. It can be a secondary complication, but not primary.
Not primary. Okay. Thank you very much.
Okay. Somebody is asking, is it hereditary? Yeah, there could be an immune dispositions. Another person is asking in the chat, please, are people with big tummy prone to pancreatitis? Please, no. So please, I want to know the prevalence and some of the differential diagnosis of it. For prevalence, there are a lot of books, but you only hear of the US data. Africa, we don't have data to that. That is why I didn't waste time on that. And that the differentials, yes, jaundice can be there. Increased serum amylase can be there. Protein indigestion can also be there as a differential. And the cardinal sign is what? We are saying that epigastric abdominal pain with golden and tenderness that radiate to the back. That is a cardinal sign. Please, how do one do cleansing of the pancreas? Please drink more water. And that you almost be sure that you are not forming a lot of precipitates. Okay? So now we come back here. Antoinette.
Please, I want to get some clarification about this. Please, about the pathophysiology. You were saying that when the enzymes become activated, while still in the pancreas, cause damage to the pancreatic cell. So meaning that the activation of the enzymes leads to inflammation and edema. So my question is, you give specific signs and symptoms, that is abdominal distension and the gorging. So I want to know, is it the activation of the enzymes that causes the inflammation and the edema? Meaning that it's a specific technique or specific signs.
Hello, Antoinette.
Yes, sir.
Again, please.
Pardon?
Can you come in again?
Hello?
Yes, I can hear you now. Please come again.
Sir, please, you were saying that in the pathophysiology, when the enzymes become activated, while still inside the pancreas causes damage to the pancreatic cell. And the activation of the enzyme leads to the inflammation and edema. So, boss, I'm asking that you gave the signs and symptoms that abdominal distension, that is gorging. So I want to ask that, is it because of the edema that you can easily identify the abdominal distension and the gorging as a specific
Yes,
signs
it
and
is just the
symptoms.
edema and inflammation coming together.
Okay.
Yeah, so you just see, instead of, for all of us, when we stand straight, right? You see the standard part of the abdomen is always lower, right? But for them, you see the lower part of the abdomen being flat, but the upper part golden out because of inflammation, edema. So yes.
Thank you, sir.
You are welcome. Constance, have you been answered? Constance.
Yes, please. I have. Thank you.
Okay, so let's take Edward as our last person. I think Diana has been sorted, so let's take Edward.
All right, thank you very much, sir. With regards to what one of my colleagues asked about pseudosis,
Edward, your network is
I
cutting
want to
out.
believe that in
Kindly
chronic
reposition and get back to us, okay?
Hello, sir. Hello.
Hello, Edward.
Hello.
Edward, please come again. I couldn't hear anything from you.
All right, sir. I'm asking that about the formation of the pseudosis. I want to believe in a chronic pancreatitis. It can lead to
Hello?
this formation because
Hello, Edward.
Hello.
Hello. Please,
Sir,
your
please,
network
can
is
you hear me?
cutting. Hello. Edward, please kindly reposition and get back to us, okay? We can't hear you well. Your network is cut. Lisbeth.
Hello, sir.
Yes.
Please, I want to ask. I managed a patient with such a condition before, and each time you check his pulse, the pulse is very rapid. I want to know why it's so.
It might be due to metabolic issues, okay?
Okay, sir. Thank you.
Yes. Ruth. Hello, Ruth.
Yeah. Hello, sir.
Yes,
Please,
Ruth.
I wanted to ask that in the courses of pancreatitis, there was no diabetes, and you also said that pancreatitis can also cause diabetes.
Yeah, pancreatitis may lead you into diabetes, but diabetes doesn't lead directly into pancreatitis.
So it means that those who have diabetes mellitus, they are not at risk of getting pancreatitis.
They are not at a cardinal
risk.
Yes.
Hello, sir.
risk.
Yes, please.
Okay, thank you, sir. Thank you.
You're welcome.
Yes, can we have Edward back again, please? Edward was making a point. Edward, can you come back again? We have only 5 minutes to go. So let's go to Elizabeth. Elizabeth Owusu, I think you've insulted. So let's go to Johnson.
Hello, sir.
Yes, Johnson.
Yeah, please, I want to know, how does the bile stone form in the pancreas?
It doesn't form in the pancreas. When you look at anatomical structure, you have the common bile duct. Now into the ampulla of Vata. So that is where it is formed.
Oh, okay.
I hope you understand that. Hello, Johnson.
Hello.
Yes, it's not formed inside the pancreas. It's formed in the common bile duct or the ampulla of Vata.
Okay.
It's only a reflux that can send a stone into the tip of the pancreatic duct, but not necessarily in the pancreas. Are you there?
Okay, thank you very much.
You're welcome. Let's go to Jessica.
Hello, sir.
Jessie, yes.
Yeah, please, someone asked the question that she was managing a patient with pancreatitis and was having a rapid pulse. And he said it may be due to metabolism issues. I want to know, is it
Metabolic
drug
disproportions.
disproportion?
Yes. Now listen to this.
Okay.
The pancreas itself has endocrine duties, okay?
Yeah, yes.
And that
Yes.
the alpha cells are there, the beta cells and the gamma cells are there. We know that the gamma cells also has to do with aldosterone metabolism, right?
Okay.
Aldosterone also have effect on your adrenaline functionability. Are you there?
Yes,
So yes,
please.
there's a possibility of it causing metabolic disproportions.
Okay.
It's a long pathway, but not necessarily a primary, cardinal symptom. However, there can be a pathway that can lead to that.
Okay. Thank you, sir.
Edward, last question and then we close.
Yes, sir.
Edward, you're on board.
Okay. My clarification is based on what one of my colleagues asked about the pseudocyst formation.
That is the edema. When there's edema. Pseudocyst is when there's collection of fluid and then it causes edema, right? And when that is when you feel the burden.
Yes, she asked whether there can be pseudocyst formation. I know that in pseudocyst formation, when the cells of the pancreas become inflamed or when they are injured and the pancreatic enzymes start to leak, then it leads to pseudocyst formation. So in the case of pancreatitis, when there's chronic inflammation of the organ, so don't we think it can lead to pseudocyst formation?
It can. It can, okay? And that is it's a pseudocyst that makes you feel the Gordon, like you type the abdomen and there's Gordon. You get it?
Okay. Okay.
Good.
All right, thank you.
So I guess let's take last one, watch it down and we are done. Watch it down. Last question.
Hello, sir.
Yes, watch it down. Please come on board. Watch it down, Lydia.
I said what I'm about to ask, it's not related to pancreatitis.
Don't worry, ask it. I will answer you.
Okay, so I have a friend there. She's been having palpitations and then chest pains. And then when she went to the hospital, she was ordered to take ECG scan and then a chest X-ray. And then it all turned out to be normal. And then the doctor told her that with the signs that she's exhibiting, it could be related to any of the GI disease. So he's treating it as GERD. So she was given clarithromycin. Okay, she tested positive for H. pylori infection, right? So she was given clarithromycin and then amoxicillin plus omeprazole. She's taking the drugs, yet the chest pains. She said she still experienced the chest pains, and then it's sudden, it's sharp, and then sudden too.
I think the doctor is wrong. When you check in when there's palpitation, there's high pulse. Most of the time we treat it as cardiac arrhythmia, right? And I just treated one rotation nurse at my place with it. I only gave her atenolol. The pulse rate came down. The palpitations went down. She's happy just 1 week ago. So I think she needs to go to a better hospital, get proper diagnosis so that they can put her on a beta adrenergic and she'll be fine.
Please, what about the chest pains?
The chest pain, it can be angina. Have you heard of angina pectoris before?
Yeah, I have.
It can be an angina.
Oh, okay.
So typically you have to go to a proper hospital, get proper diagnosis, and then they treat you, right? Like I told you when we were doing GERD, I said most GERD will come like chest pain. When you do the first line, it's not working, then you think about cardiac, right?
Okay.
So it's better she get a better doctor. We are not saying that doctor is not good. He did the first line. If it's not working, go to another one, get proper diagnosis, and you'll be fine. Okay?
Oh, okay. All right. Thank you, sir.
Okay, so I think my time is up. We have taken a lot of time to answer and ask questions. And I have less than a minute to go. Antoinette and my other coursework, where are you? Where are my
Sir,
two
I'm here.
courseworks? Hey, could you
Sir,
ask
Your
someone,
Honor.
is there any concern?
So far, so
I
good. We
guess
don't have
you
any concern for now.
okay, good. So Antoinette, she didn't bring me some of the mosquito net, right?
Oh,
Also,
sir.
yeah. So I guess we'll call it a day. Enjoy your time and that. Inshallah. I think next week we have to meet face to face, right?
Oh, okay.
They've not scheduled that for now,
You've
so
not
we
given the
can.
schedule.
Yeah.
Okay,
No,
okay.
please.
We are
So
not
I
aware of
wish
it.
to see all your big heads and then the small faces too. So in that regard, we'll call it a day. Have a nice day and that enjoy your weekend. Bye
Thank
bye.
you.
Thank you very much. We appreciate it.
Thank you.
Thank you, sir. So I'll be waiting for the slides.
Okay, I'll forward it to you.
Okay.
Thank you.
Thank you.
Thank you.
Thank you, sir. Okay, okay.